Welcome back to the deep dive. Today, we're jumping into a topic that's, well, it's a world measured by hope, by optimism, and just a relentless flood of statistics.
Oh, absolutely.
Yeah.
And those stats often become the deciding factor when you're looking for fertility treatment.
They really do. And our mission for this deep dive is to get into the source material that reveals the hidden mathematics behind those numbers.
That's right. Because the single most crucial thing to understand is that a clinic success rate isn't one fixed number. It's a calculation game.
Okay, let's unpack that.
Right.
When you see a banner online or on a billboard that says, IVF success rate equals 65%, the one question you have to ask is,
65% of what?
exactly. And the answer is almost never that simple.
It's fascinating because the choice of a starting point can completely change the outcome, even with the exact same group of patients.
So what are the options? I saw that one way is to report the live birth rate, the LBR per cycle started.
Yes, and that is by far the most honest baseline. It counts every single person who begins treatment. No one gets left out of the math.
Okay, but what's another way?
Well, they could report success per egg retrieval.
Yeah.
And right there, that's a jump point.
How so?
Because you've already excluded patients whose cycles got canceled before they even made it to retrieval. Maybe due to a poor response to the meds.
Got it. And then there's the really big statistical leap, right? Reporting per embryo transfer.
That's where the numbers can really start to look inflated. You filtered out everyone who didn't produce a viable embryo or whose cycle was stopped for any other reason.
And it can get even more specific, can it? Like per blastocyst transfer, or I saw the term per eukloid embryo transfer.
Yeah, and just for clarity, euploid just means the embryo was genetically screened and found to have the correct number of chromosomes. It's another filter.
Let's use that example from our source material because it makes it so clear. Let's say a clinic starts with 100 patients.
Okay, 100 patients. And over the year, that clinic helps bring 20 babies into the world. 20 live births.
So if they report that, honestly, per cycle started, their success rate is 20%.
A transparent 20% live birth rate. That's the real outcome for those 100 people who walk through the door.
But what if they only report per transfer? Maybe only 60 of those 100 people actually made it to a transfer.
Then suddenly that same clinic with the same 20 babies has a 33% success rate. It's statistically true for the transfers they did, but it hides 40 cycles that didn't get that far.
Wow. And what about per upload transfer?
That number could easily soar past 50%. It's the same clinic, same babies, but three totally different truths.
So the takeaway is you have to demand the LBR per cycle started.
It's the only way to see the full picture.
Okay, so that's the math. Now let's talk about the strategy. How do clinics kind of influence the inputs before treatment even begins? This idea of invisible filtering.
It's all statistical optimization, and it starts with patient selection. Clinics know exactly what a statistically perfect patient looks like.
And that is?
Generally, under 35, good ovarian reserve, which is often measured by a high AMH level, and just generally no major underlying issues.
So what happens to the patients who don't fit that perfect profile, the ones whose stats might be less favorable?
Well, often they're subtly discouraged or even redirected because including them would bring the clinic's shiny success rates down.
So we're talking about women maybe over 38 or with a low AMH?
Exactly. Or people with a history of recurrent implantation failure, RIF, as it's often called, or severe male factor. These are complex cases.
And they require really personalized medicine, but they carry a lower chance of a quick, easy success.
Right. And this ties directly into those guarantee programs. The money-back packages.
They sound so appealing, like a safety net.
They do. But their very existence is an incredibly effective statistical filter.
How does that work?
Think about it. To get into one of those programs, you already have to have a very high predicted chance of success, usually 70% or more, based on your age and diagnosis.
So they're not accepting the difficult cases into the guarantee program.
Not at all. The program boosts the clinic's stats because the patient pool is pre-selected for success. The high success rate comes from the selection bias, not necessarily from a superior medical approach for everyone.
That is a really powerful insight. Okay, let's move on. Beyond selection, what about the actual clinical decisions made during treatment? We saw that some protocols aim for quantity over quality.
They do. In this statistical game, more eggs can feel like more chances. So some clinics will push for really high egg numbers with their drug protocols.
Even if that might compromise egg quality.
Potentially, yes. Or it could create high estrogen levels, which risks what we call an endometrial mismatch. Basically, the uterine lining isn't perfectly receptive when it's time for implantation.
But the mindset is just get more eggs, get more blastocysts, and you get more potential positive tests to report.
That's the idea. But maybe the most effective tool for, let's call it statistical erasure, is cycle cancellation.
This feels like a really crucial point.
It is. If a clinic sees a cycle isn't going perfectly, maybe a slow ovarian response, not many eggs, they might cancel it. They'll call it a poor response.
And here's the kicker, right? If a cycle is canceled before the transfer stage, it often just vanishes from the official data.
It never enters the stats for LBR per transfer. The patient's journey is paused. It's a really difficult moment for them, but the clinic's failure rate stays clean.
So a patient's failure might not even count as a failure in the clinic's official numbers?
If it's canceled early enough, yes. It's a way to keep the denominator small and the percentage high.
This also seems to connect to genetic screening, PGT-A. It's a medical tool, but it's also a statistical one.
It's both. PGT-A has real medical value, especially for certain patients. But by its nature, it filters out the embryos that were chromosomally abnormal.
The ones that probably would have failed to implant anyway or would have ended in miscarriage.
Precisely. So by only transferring the genetically normal or euploid embryos, the clinic instantly and dramatically improves its success rate per transfer.
The patient's biological reality hasn't changed. Those non-viable embryos still existed, but the clinic's reported failure rate goes way down.
It's a powerful tool for statistical optimization. It's important for you to understand that context when you see those numbers.
Okay, let's talk about the final stage, the reporting tricks, the fine print. What about fresh versus frozen cycles?
Good question. Some clinics might highlight their fresh cycle success rates, which are often driven by younger patients with great outcomes.
But a lot of advanced clinics use a freeze-all strategy for medical reasons, right?
Yes, to let the uterus recover from the stimulation drugs or to prevent hyperstimulation. A top-tier clinic that treats complex cases might have freeze-all stats that look lower than a clinic cherry-picking easy fresh cycles.
So again, a lower statistic doesn't always mean lower quality of care.
Not at all. And then you have the age trap. A clinic will shout from the rooftops that their success rate for patients under 35 is 75%.
Which is amazing.
It is, but they might whisker, or just not mention, that their rate for the 40-plus group is, say, 15%.
And the overall number they advertise is propped up by the younger group. So you have to ask for the data that applies to you, your age, your diagnosis.
And this brings us to what might be the biggest trick of all, the one you absolutely have to watch out for.
Which is?
The difference between the pregnancy rate and the live birth rate.
Let's just pause on that, because getting a positive pregnancy test is incredible news, but the real goal for everyone going through this is bringing a baby home.
Exactly. A clinic might advertise a huge 65% pregnancy rate, but that number includes chemical pregnancies that disappear in days and clinical pregnancies that might end in an early miscarriage.
So what's the actual live birth rate, the LBR, in that scenario?
It could be as low as 40%. The drop-off can be absolutely staggering.
That's the ultimate fine print. You have to look for the LBR. Always. Because that emotional success of a quick positive test might be more about luck and selection bias than about a superior medical strategy.
So the big picture here is that IVF is science. It's biology. But it's also statistics, economics, and, frankly, marketing psychology. A clinic's high success rate might say more about their filtering and reporting style than it does about your personal chances.
But this is all about empowerment. Now you know the right questions to ask, the questions that cut through that marketing noise.
First, just ask them directly. Do you publish your live birth rates per cycle started, not just per transfer? That's the gold standard for transparency.
And second, you need to understand who they treat. Ask them. Do you take on patients with low AMH, patients over 40? Or with a history of repeated failures?
Their answer tells you if they're willing to handle complex cases or if they prefer to stick to the easier ones.
Third, and this is a big one, how often do you cancel cycles, and are those cancellations counted in your failure stats?
That tells you how quickly they might give up on a cycle that isn't looking perfect on paper.
And finally, can I see your success rates broken down by my specific age group and my diagnosis?
Right. If a clinic hesitates to share that data, well, that's an answer in itself.
It all comes back to transparency.
It does. And remember, your journey is your own. You are not a percentage. You're a person. The right clinic is the one that measures success with transparency and personalized care, not just with optimized numbers.
We do want to remind you that this discussion is exclusively for educational purposes and should never be taken as medical advice. You must always consult with qualified medical professionals for your specific situation.
For more comprehensive information on the entire IVF process, you can find great resources on the portal, ivfforme.com.
Thank you so much for diving deep with us. We'll catch you next time.